Okay, let's dive in. Picture this. You're faced with a severely injured patient. Things are chaotic, multiple problems happening at once, and, well, time is absolutely critical.
It really is.
Yeah.
And dealing with that chaos effectively, it requires a very systematic approach. It's not just about knowing things, it's about a process.
Exactly, and that's what we want to really get into today. We're drawing on the kind of core principles you'd find in, well, a top-tier surgical text. The goal here isn't just a quick overview.
No.
We want to go deep, understand every key step, the why behind it, really internalize it like the professionals who do this every day. Get that kind of mastery level.
That's a great goal. And, the first thing to grasp is that this whole process, it doesn't just kick off when the ambulance doors open at the hospital.
Right, it starts much earlier.
Yeah, absolutely. Management begins pre-hospital right there at the scene.
Okay, so how does that work? How do they identify these severely injured patients so early on?
Well, often it's pretty obvious from the mechanism, a major crash or fall. But the absolutely crucial step then is the pre-alert, calling ahead to the hospital.
Forewarning them, basically.
Exactly. Telling them what's coming so the trauma team can be activated and ready to go the second that patient arrives. It saves critical minutes.
Makes sense. What details absolutely need to be in that pre-alert call?
Okay, so the basics. Age, gender. Then, critically, the mechanism of injury, what actually happened, any injuries they've already identified at the scene, and, of course, the patient's vital signs.
Which are?
Respiratory rate, pulse, blood pressure, and their GCS, the Glasgow Coma Scale score. That initial snapshot is key.
Now, here's something the source really emphasizes, and it feels like a hard-earned lesson. Not all severe trauma looks severe initially.
Oh, this is so important, really vital. Think about, say, an older person who's maybe just fallen down a couple of steps. They might seem okay talking, even.
Yeah, maybe complaining about their hip a bit.
Right. But underneath, they could have devastating injuries. A fractured hip, yes, but also maybe rib fractures messing with their breathing, or even a slow bleed inside their head, a subdural hemorrhage, things that can kill them if not picked up.
So the outward appearance can be really deceptive.
Totally deceptive, and that's the core message. Whether the severe trauma is obvious or whether there's just a high risk of it because of, say, the mechanism or the patient's age, they all need that trauma team activation. They all need the same structured approach, no cutting corners based on how they look at first glance.
Which brings us squarely to the trauma team itself. Why is having this dedicated team ready to go instantly so non-negotiable for hospitals dealing with this level of injury?
Because time is everything, and you need multiple experts simultaneously. You can't afford to wait 5 minutes for the anesthetist to arrive, then another 5 for the surgeon.
You need everyone there at once.
Exactly. Emergency docs, anesthetics or critical care, trauma and orthopedics, general surgery, that's the core. And increasingly, you're seeing radiology and hematology looped in early too. Imaging and blood products are often needed right away.
The source mentions something called an enhanced trauma team activation, a code red. What triggers that higher level?
Ah, right. That's for the absolute sickest patients, the ones identified, usually pre-hospital, as being hemodynamically unstable, basically, in shock, their circulation failing or having an acute airway problem they can't manage. These are patients right on the edge.
And the response is automatic for a code red.
Completely, no delays. The most senior people from each specialty, they're expected to be there before the patient even hits the door. And often, the massive transfusion protocol gets activated pre-hospital too, based on that code red call. Blood products are already being prepared.
Okay, team's assembled, patient arrives. What's the immediate game plan?
It's all about applying the ATLS principles, advanced trauma life support. The absolute first priority is the primary survey. Find and fix the things that will kill the patient in the next few minutes.
And this is where the team aspect really shines, isn't it, compared to one person working alone?
Oh, massively. The key advantage is concurrency.
Yeah.
Doing things at the same time.
So not just A, then B, then C.
No way. You've got the airway expert focusing on A, someone else immediately assessing B breathing, another getting IV access and checking C circulation, all happening simultaneously. It compresses that critical assessment time dramatically.
And the person holding it all together, the trauma team leader, what's their job?
It's huge. They're coordinating everything, briefing the team, managing the clock, listening to the reports coming in from everyone, interpreting those findings, and then making the call. What's the next step? Do we need imaging? Straight to theater? More resuscitation first?
It sounds like more than just medical knowledge.
Oh, much more. Yes, you need the medical skills, absolutely. But the non-technical skills are just as crucial. Leadership, crystal clear communication, decision-making under immense pressure, managing all that information. It's why there's specific training now just for trauma team leaders.
And where they stand physically actually matters.
Yeah, the source suggests the leader and maybe other senior clinicians should ideally stand back slightly, get that helicopter view of the whole situation. It helps them oversee everything, anticipate problems, and coordinate, rather than getting tunnel vision on one specific task.
Okay, let's break down that primary survey. The goal: find and fix immediate life threats. And it follows CABCDE. Why the Betty's at first? I thought it was always ADC.
Ah, that's a really key change, driven largely by military experience filtering into civilian practice. If a patient has catastrophic external bleeding, like a massive arterial bleed from a limb, that can kill them even faster than an airway problem.
Right, bleeding out in seconds.
Exactly. So if you see that kind of exsanguinating hemorrhage, you control that first. Then you worry about the airway.
How do you control it? Right there on the spot.
Direct pressure. Get packs, hands, whatever you have, right onto the wound and push hard. If you can identify the artery feeding it, press on that proximally too. And we now have hemostatic dressings available, impregnated with agents to help clotting.
What if direct pressure isn't cutting it, especially on an arm or leg?
Then you reach for a tourniquet. Needs to go proximal to the wound, tighten it until the bleeding stops. But, and this is critical, applying a tourniquet makes the limb ischemic.
Cuts off all blood flow.
Correct. No oxygen getting to the tissues. So you absolutely must record the time the tourniquet was applied, write it on the patient, make it obvious, because that clock is ticking. They need to get to surgery urgently to control the bleeding source properly and get blood flowing back to that limb reperfusion.
Okay, a catastrophic bleeding dealt with. Then airway with cervical spine control. What's the absolute non-negotiable here?
Every single trauma patient gets their cervical spine immobilized and protected, period. You assume there's a neck injury until proven otherwise, usually with imaging later. Collar, blocks, the whole setup.
And assessing the airway itself.
Listen, feel. Is it open? Can they talk? Is there blood, vomit, debris? If it's compromised, you work through steps. First, clear it out suction.
Okay.
Then simple maneuvers. Jaw thrust, chin lift. Try to open it physically. If that's not enough, you can try simple adjuncts in oropharyngeal airway, the Guedel, or a nasopharyngeal airway.
And if those don't work either?
Then you need an advanced airway. Usually that means intubation, placing a cuffed endotracheal tube into the windpipe. This almost always needs drugs, anesthesia, using rapid sequence induction to facilitate it safely. And sometimes, if you can't intubate from above...
Then what?
Then you might need a surgical airway, a cricothyroidotomy, cutting through the neck into the airway.
Wow. Intubating a crashing trauma patient sounds incredibly difficult.
It is. Facial injuries, neck swelling, blood in the airway... The patient's instability, it's high risk. That's why the source stresses having clear practice drills for failed intubation. You need Plan B and Plan C ready instantly. And the equipment and skills for that surgical airway have to be right there, immediately available. Because sometimes it's the only option left. You know, the image in the source, that kind of severe facial injury, that screams potential airway disaster and need for C-spine control.
Got it. Airway sorted, C-spine safe. Next is B, breathing and ventilation.
Standard first step. High flow oxygen for everyone. Then, the immediate priority is to find and fix the life-threatening chest injuries that stop the patient breathing properly or mess up their circulation.
And the big three are?
Tension pneumothorax, air trapped in the chest, squashing the lung and heart. Massive hemothorax, the chest filling up with blood. And a flail segment, broken ribs making part of the chest wall suck in instead of expanding.
And how do you fix those quickly?
You need the kit and the skills ready for rapid insertion of chest drains. Needle decompression for a tension pneumothorax maybe first, then a formal drain to let the air or blood out. Life-saving stuff, done right there in the resus bay.
Okay, on to C. Circulation and hemorrhage control. This feels like the real engine room of the primary survey once the airway's secure.
It really is. So much happens here. First, access. You need good IV access, ideally 2 large bore cannulas, usually in the crooks of the elbows. If you can't get peripheral lines quickly.
Then what? Central line?
Yeah, central venous access or intraosseous IO access.
Yeah.
Drilling a needle into the bone marrow, usually the top of the tibia or the humerus. It gives you rapid access to the circulation.
And you're drawing blood immediately.
Yes, straight away. Blood for cross-matching, so the lab can get compatible blood ready. And for baseline labs hemoglobin, to see how much blood they've lost. And really importantly, venous lactate.
Lactate, we'll come back to that. How do you quickly spot if someone's in shock from blood loss?
You assess their hemodynamics. Are they pale, cool, sweaty? Is their pulse fast, usually over 100? Is their blood pressure low? These are the classic signs of shock, core perfusion.
And for blunt trauma patients in shock, there's that immediate action.
The pelvic binder, yes. If they're hemodynamically unstable after blunt trauma, put a pelvic binder on. Assume they might have a pelvic fracture bleeding internally until proven otherwise. And crucially, do not take it off until imaging has cleared the pelvis. It can tamponade significant bleeding.
And the core assumption about any trauma patient with low blood pressure.
They are bleeding until proven otherwise. Treat them as hypovolemic. So the twin priorities are resuscitate them, give them back volume, and you'll find out where the bleeding is coming from and stop it. Those have to happen together.
Okay, let's dig into these resuscitation strategies. First up, permissive hypotension. Sounds risky, letting the blood pressure stay low.
It sounds counterintuitive, I know, but the idea isn't to get the BP back to normal right away. The goal is just to keep it high enough, say, a systolic between 70 and 90 millihg to perfuse the essential organs. Brain, heart, kidneys, just enough flow.
But not always that low.
Right. The big exception is suspected head injury. Then you need a higher pressure, maybe targeting above 90 systolic, to ensure enough blood gets to the injured brain.
How do you achieve that target pressure without overdoing it?
Small, careful boluses of fluid. The source suggests maybe 250 milliliters of O-negative blood if it's ready, or saline if not. Give a small amount, reassess. Can you feel a radial pulse now? Okay, maybe hold there for a moment.
And what are you desperately trying to avoid giving too much of?
Crystalloid solutions like normal saline or colloid solutions. Huge volumes of clear fluids are actually harmful.
Harmful, but they need fluid, don't they?
They need blood. Pouring in liters of saline just dilutes everything. It dilutes the remaining red cells, their clotting factors, their platelets. It makes them more coagulopathic, less able to clot. It worsens the bleeding, plus it increases the risk of lung injury, ARDS, down the line.
So keeping the pressure a bit lower helps stop clots being blown off, and giving minimal clear fluid avoids making the clotting worse while you try and get blood into them.
Precisely. You're buying time. But, and this is the critical part, permissive hypotension is strictly time-limited. It's a bridge to definitive hemorrhage control. You cannot just keep them hypotensive indefinitely. You have to find and fix the bleeding AST, whether that's in theater or interventional radiology.
Which leads perfectly to massive transfusion protocols, MTPs. This is about replacing what they're losing.
Exactly. Forget the bags and bags of saline. Severely bleeding trauma patients need blood and blood products, red cells, plasma, platelets, and these products must be warmed. Giving cold blood makes the patient hypothermic, which, as we'll see, makes bleeding even worse.
What's the ideal mix, the ratio the source mentions?
It's generally aiming for a balanced resuscitation. A ratio of 1 unit of packed red cells to 1 unit of fresh frozen plasma to 1 unit of platelets.
So oxygen carriers, clotting factors, and clot building blocks altogether.
Yeah, trying to replicate whole blood as closely as possible and actively treating that developing coagulopathy. Every hospital dealing with major trauma needs a robust, easy-to-activate MTP.
Okay, and the third piece of the resuscitation puzzle, tranexamic acid, TXA. What's that do?
TXA is an antifibrinolytic. Basically, it helps stop clots being broken down too quickly by the body. It stabilizes the clots you are managing to form.
And the benefit in trauma.
It's proven to reduce mortality from bleeding. Simple drug, big impact in both blunt and penetrating trauma.
How's it given?
A standard dose is 1 gram IV over about 10 minutes, then another 1 gram infused over the next 8 hours.
Who gets it? Anyone bleeding?
Pretty much any trauma patient with suspected significant hemorrhage, often triggered by signs like systolic BP under 110 or pulse over 110. But the absolute key is timing, as early as humanly possible. Ideally within the first hour of injury. The benefit drops off sharply after 3 hours, so you shouldn't give the first dose later than that. It's so important that paramedics often give it pre-hospital now.
Okay, so putting that resuscitation strategy together. Give TXA early, activate the MTP for balanced transfusion with warm blood, plasma, platelets in a 1.1.1 ratio, and use permissive hypotension with minimal crystalloid as a temporary bridge until bleeding is stopped.
That's the modern approach in a nutshell. Resuscitate with what they're losing.
While all this resuscitation is happening, you're urgently trying to figure out where the bleeding is. What are the usual suspects, the common sites?
You think blood on the floor and 4 more. So external bleeding you can see, then internally. The chest, the abdomen, the pelvis, and fractures of the big long bones like the femur can hold a lot of blood. And in blunt trauma, it's often bleeding from multiple sites at once.
So the goal of your examination and tests is to quickly rule these sites in or out.
Yes. And the absolute cornerstone investigation for figuring this out in major trauma, according to the source, is the CT scan.
The whole body CT, the WBCT.
That's the one. A rapid scan from the top of the head down to the pelvis, done with intravenous contrast. It gives you a detailed look inside all those potential bleeding cavities. It's the standard for patients with signs of multiple injuries or abnormal physiology.
But not just for anyone involved in a bad accident.
No, that's a key point the source makes. You don't do a WBCT just because the mechanism was bad. There needs to be a clinical indication concerning signs or symptoms, abnormal vital signs. Mechanism is a risk factor, but doesn't automatically trigger a scan.
And you scan the whole lot, not just, say, the chest if they have chest pain.
Correct. If a major trauma patient needs a CT, they get the full head-to-pelvis WBCT. No selective scanning in this context. You need the full picture.
Is it urgent? Does it need to happen quickly?
Hugely time critical. You want it done as early as possible in the resuscitation phase. And the radiologists are geared up for this. They'll often provide a quick verbal hot report within minutes, telling the trauma team about any immediately life-threatening findings, like massive internal bleeding, before the full detailed report is ready.
What about the old school x-rays, like a chest x-ray or a pelvis x-ray in the resus room?
They're becoming less common as the first step, especially in centers with easy, rapid access to CT. Why waste time with limited x-rays if you can get the definitive, comprehensive WBCT quickly? Many trauma centers now have CT scanners right next to or even inside the resuscitation area.
That must make a huge difference.
It does. It means even patients who are quite unstable can potentially get their WBCT done safely because the trauma team can be right there with them, continuing resuscitation in the CT scanner itself.
But there must be a point where a patient is just too unstable to go to CT.
Absolutely. And deciding where that line is, that's one of the toughest calls for the trauma team leader. It really depends on how sick the patient is, how they're responding, and what your local setup is like. If they're actively exsanguinating, taking them away from immediate surgical capability could be fatal.
So what happens to those patients, the ones too unstable for CT?
They go straight to the operating theater for immediate surgical control of bleeding. The most likely culprits needing that kind of immediate surgery are massive bleeds in the abdomen or the pelvis.
Do they get any scans before theater?
Very minimal. Usually a quick portable chest x-ray to rule out a huge hemothorax or tension pneumothorax, and a pelvic x-ray is essential, but you don't delay going to theater for it if the patient is crashing. A fast scan, that quick ultrasound at the bedside might be done if available, just to help confirm if the abdomen is the likely source.
And the pelvic binder.
Yeah.
Relevant here too.
Absolutely critical. Any unstable patient going for an emergency laparotomy for blunt trauma should have that pelvic binder applied and left on. It doesn't get in the way of the abdominal surgery if positioned correctly over the trotanders.
And presumably, these patients who went straight to theater, they'll still need a CT scan eventually.
Oh, for sure. Once the bleeding is controlled surgically and they're stabilized a bit, usually in the ICU, they will get a full WBCT to look for any other injuries that were missed.
Okay, let me try and summarize the WBCT strategy to lock it in. Gold standard for major blunt trauma if they're clinically indicated. Do it early. Do the whole body, head to pelvis. Don't scan just based on mechanism. Pelvic binder stays on. If they're too unstable, it's straight to surgery, often with just basic x-rays, and they get the CT later.
That's a really good summary. Captures the key decisions around imaging C.
Right. Moving along the primary survey, D for disability and E for exposure. What's involved in assessing disability?
It's your initial neurological snapshot. Calculate the GCS score looking at their eye-opening verbal response, motor response. Check their pupils. Are they equal? Are they reacting to light? And quickly check if they're moving all four limbs.
And E for exposure.
It means you have to get all their clothes off so you can do a proper examination, usually during the secondary survey. But exposing the patient immediately brings up a really critical point.
Temperature.
Exactly.
Oh.
Maintaining the patient's core body temperature. Trauma patients get cold very easily from exposure, from shock, from cold fluids if you're not careful, and hypothermia is disastrous.
Why disastrous?
Because it massively worsens coagulopathy. Cold patients cannot clot properly. Their whole clotting system just doesn't work efficiently below normal body temperature. It feeds into that lethal triad: hypothermia, acidosis, coagulopathy. So you have to actively fight hypothermia from the moment they arrive. Record their core temp, minimize exposure, use warmed blankets, warm trolleys, and absolutely use fluid warmers for IV fluids and blood products.
And spine protection continues through D&E.
Yes, full spinal precautions remain in place, the collar, the blocks, careful handling using log rolls if needed until a spinal injury is ruled out, which, again, that early WBCT is very good at doing for most significant injuries.
Okay, you mentioned log rolling. The source flags some really important practical points and maybe controversies about this.
Yeah, this is crucial real-world stuff. While log rolling is the standard way to maintain spinal alignment when turning a patient, doing a full log roll on someone with a significant pelvic fracture can actually be harmful.
How so?
It can dislodge the very blood clots that might be forming around the fracture site, potentially restarting or worsening life-threatening pelvic bleeding.
So what's the rule now?
Don't do a full log roll until you know the pelvic status.
Wow.
Exclude a fracture radiographically first with that initial pelvic X-ray or the WBCT.
But you might still need to move them slightly, like onto the CT scanner.
Right. In that case, a gentle 20-degree tilt or log roll with someone maintaining inline spinal stabilization is considered safer before the pelvis is cleared. And modern scoop stretchers often mean you don't need to roll them much more than that anyway.
What about the idea of log rolling every blunt trauma patient during the primary survey just to check their back?
The source argues strongly against this now. It generally adds very little useful information at that immediate stage. It definitely delays getting them to the definitive WBCT scan, and it carries that risk of harming them if they have an unstable pelvic fracture. So for blunt trauma, examining the back can usually wait until after the primary survey and the WBCT, unless it's penetrating trauma. If someone's been stabbed or shot, you do need to roll them early to look for an entry or exit wound on their back. That's the exception.
Okay, and another don't related to the pelvis, something called springing.
Yes. Never, ever spring the pelvises, meaning manually pushing on the pelvic bones to check for instability. It provides zero useful clinical information that you won't get from imaging, and it will disrupt clots around a fracture and can cause massive bleeding. Just don't do it.
So diagnose pelvic fractures with imaging only. Don't poke them.
Exactly. Trust the radiology.
That's incredibly useful practical detail. Right, that wraps up CABCDE. Just hitting C one last time. Circulation means access, shock assessment, pelvic binder for unstable blunt trauma, and don't take it off. Resuscitation with warmed blood products via an MTP, TXA early, permissive hypotension temporarily.
You've got it. Integrating all those elements under C is critical.
So the immediate life threats are hopefully stabilized. What comes next? The secondary survey.
Correct. Once the primary survey is complete and you've addressed the immediate killers, you move on to the secondary survey. This is a much more detailed, systematic head-to-toe examination, looking for all the other injuries.
Doesn't always find everything.
Not always. If the patient is intubated, unconscious, you can't get feedback from them, so some things might still be missed.
Which is why there's also a tertiary survey.
Exactly. This happens later, often days later, when the patient is ideally awake, alert, and can cooperate. You specifically go looking for those injuries that were missed earlier.
What kind of injuries are we talking about? Things that aren't immediately obvious.
Yeah, the source gives examples like a scaphoid fracture in the wrist, maybe a rotator cuff tear in the shoulder, things that won't kill them, but
could cause long-term problems if missed.
precisely. They can lead to significant pain, disability, loss of function down the line if not picked up and treated. So that tertiary survey is really important for long-term outcome.
And documentation throughout all these stages, primary, secondary, tertiary, is vital.
Absolutely essential. Clear, accurate records of all findings and interventions are crucial for continuity of care, communication between different teams and specialists, and medico-legally as well.
Okay, assessment done, initial management done, imaging results coming back. Now we get to the big strategic decisions about surgery. The source contrasts damage control surgery, DCS, with early total care, ETC. Let's unpack DCS first. Why did this concept even come about?
It came from the realization, really, that very sick trauma patients, the ones who are cold, acidotic, and coagulopathic, that lethal triad, again, did incredibly badly if you subjected them to long, complex, definitive operations straight away.
The surgery itself was making them worse.
Yes. The second hit of a major operation on an already physiologically devastated patient was often too much. It just deepened the shock, the acidosis, the hypothermia, the coagulopathy, and pushed them into multi-organ failure.
So damage control surgery is a fundamentally different approach for these really unstable patients.
Completely different philosophy. It's about doing the absolute minimum necessary very quickly to save life and limb and then getting out. Stop the bleeding, control contamination, and that's it. No fancy reconstructions at this stage.
What kind of procedures are typical in DCS?
Things like packing bleeding sources in the abdomen or chest instead of trying to repair everything, quickly ligating bleeding vessels, decompressing compartments like doing a craniotomy for brain swelling or fasciotomies for limb compartment syndrome, maybe rapidly splinting fractures externally, removing gross contamination from bowel injuries, maybe creating stomas, just the essentials.
And the goal isn't definitive repair.
Not at all. The goal is hemorrhage control, contamination control, and then rapid transfer to the intensive care unit. You stop the operation, often leaving the abdomen packed and open, for example, and let the critical care team take over resuscitation. Warming the patient, correcting the acidosis, restoring normal clotting with blood products.
And the definitive repairs happen when?
Later, once the patient is physiologically normalized, warm, clotting normally, good urine output, lactate coming down. Then, maybe 24, 48 hours later, they go back to theater for the second look operation and the definitive reconstructive procedures.
Can you give examples? Abdomen, orthopedics.
Sure. Abdomen. DCS might be packing the liver, stapling off a bowel injury, washing out contamination, and applying a temporary abdominal closure. That's it. Orthopedics. DCS would be washing out a dirty open fracture, maybe putting on an external fixator for temporary stability, releasing compartment pressures. No internal plates and screws at this stage.
The source mentioned a really tough DCS decision regarding limb revascularization.
Yes, it's a very difficult one. If you have an isolated arterial injury to a limb, you try to save the limb by revascularizing it. But in a patient with multiple severe injuries who is profoundly unstable, spending hours trying to repair that artery might push them over the edge physiologically. Saving the limb might risk the patient's life. In those extreme DCS scenarios, sometimes primary amputation is tragically the life-saving option.
And DCS patients always end up where? Immediately after surgery.
Always back to the ICU for that crucial period of ongoing resuscitation and physiological optimization before any further surgery is considered.
Okay, so that's DCS for the sickest patients. What about early total care ETC? Who's that for?
That's for the majority of trauma patients, thankfully. The ones who, after the initial resuscitation in the emergency department, actually stabilize quite well. They're not profoundly physiologically deranged. Their bodies can tolerate definitive surgery much earlier.
How do you judge if someone is stable enough for ETC? What are the markers?
You look at their physiology post-resuscitation. Is their pulse rate reasonable, say under 100? Is their blood pressure okay? Respiratory rate okay? Are they making decent urine, maybe over 30 mils an hour?
Temperature and bloods matter too.
Absolutely. They shouldn't be significantly hypothermic, so core temp above 35 degrees. They shouldn't have significant acidosis on their blood gas, and their coagulation profile should be reasonably normal or easily correctable.
And lactate. How does that fit into the ETC decision?
Lactate is a really good indicator of their overall metabolic state and how well perfused their tissues are. The source gives some useful thresholds.
What are they?
Generally, a lactate under 2 millimol suggests they're probably well resuscitated and good candidates for ETC. If the lactate is over 3 millimol, that's a warning sign they're likely still under-resuscitated or physiologically stressed. They probably need more time in ICU for resuscitation, or if surgery is essential right now, it should be DCS. A really high lactate, say over 5. The source says that mandates DCS.
What about that gray zone, lactate between 2 and 3?
Yeah, that requires more judgment. You look at the trend, is it coming down nicely with resuscitation? And you'd weigh it up with all the other physiological parameters, temperature, urine output, base deficit, coagulation to make the call.
Who makes this critical ETC versus DCS decision?
It's a joint decision, usually between the senior surgeon and the senior anesthetist or critical care physician involved. Sometimes it's obvious the crashing patient with abdominal bleeding gets DCS. Other times it requires careful discussion and review of all the data.
And if a patient is deemed suitable for ETC, what happens surgically?
They can usually proceed relatively early with definitive repair of their injuries.
Like fixing broken bones properly.
Exactly. For musculoskeletal injuries, ETC means definitive fixation plates, rods, screws of unstable long bones, spine, and pelvic fractures, typically within the first 36 hours after injury.
And there are real benefits to getting those fractures fixed early.
Huge benefits. It makes nursing much easier, allows the patient to mobilize sooner, reduces pain, reduces complications like chest infections and blood clots, and generally shortens their ICU and hospital stay.
What if they have multiple fractures needing fixing under ETC? Do you do them all at once?
Not necessarily. It often involves serial procedures. Maybe fix the femur today, stabilize the spine tomorrow. After each operation, the team reassesses. Is the patient still physiologically stable enough for the next procedure? procedure? Or do they need a pause back to ICU for more optimization before continuing?
Okay, so summing up the surgical strategies. ETC is the preferred path for stable patients, allowing early definitive repairs, within 36 hours usually, with significant benefits. DCS is reserved for the physiologically unstable patient rapid life limb saving surgery only, followed by ICU resuscitation, with definitive repairs deliberately delayed until they're stable. And lactate is a key guide in making that choice.
That captures it perfectly. And importantly, you can always switch from an ETC plan to a DCS approach mid-operation if the patient starts to deteriorate physiologically. Patient safety always comes first.
This has been incredibly thorough. Let's just quickly recap the absolute core principles from our source for managing severe trauma effectively.
Okay. First, it all hinges on following established ATLS principles that structured CABCDE approach for assessment and immediate management.
Investigation-wise.
The whole-body CT, head to pelvis with contrast, is the gold standard for identifying injuries in major blunt trauma patients who need it based on clinical signs, done early. No selective scanning.
Resuscitation for the unstable bleeder.
It's about warmed blood products, red cells, plasma, platelets in a balanced 1.1.1 ratio via an MTP. Give TXA early. Use permissive hypotension as a temporary bridge. Avoid floods of crystalloid.
And the crucial surgical decision?
Making that early, informed choice between damage control surgery for the physiologically compromised patient, limiting the initial operation to life-limb saving steps, versus early total care for the stable patient, aiming for definitive repairs within about 36 hours. Physiology, especially lactate, guides this decision.
So mastering this really means understanding it's not just one thing. It's this incredibly complex, fast-paced interplay between systematic assessment, immediate interventions, smart use of imaging like WBCT, careful targeted resuscitation using blood products and monitoring physiology like lactate, and then making that strategic surgical call, DCS or ETC, based purely on what the patient's body can tolerate right now.
Absolutely. It requires a highly skilled team working within a well-rehearsed system, making critical decisions under pressure, always focused on saving life first, then limb, then function. It's high-stakes, demanding work.
It really is. And thinking about all that complexity, the constant pressure, coordinating the team through primary, secondary, tertiary surveys. Beyond the pure medical knowledge, what do you think is maybe the single most vital, non-technical skill for that trauma team leader? Is it decisiveness, communication, situational awareness? It's a tough one, something for everyone listening to really chew on as they consider what true mastery in this field looks like.
That's a great question to end on. Because the human factors, the team dynamics, the leadership, they are just as critical as knowing the medicine.